is horrible. I have no idea how many accidents there are out there, but I've already gotten notifications from my colleagues at the VA that many of them are going to be late to work. So I suspect we'll have people trickling in over the next 15 minutes. I have actually no specific announcements. I suspect everybody in this room has heard, that I will be leaving. January the 31st will be my last day here. I'm going to be moving. I'm taking a position at the University of Texas Southwestern in Dallas, Texas. Obviously, I'm leaving this institution with very mixed feelings because I've been here for 29 years now, and my career has been formed here. But I am absolutely confident that the university, the School of Medicine, is on the right track now, and I anticipate big growth and developments for it. So with that, I'm excited about today's Grand Rounds, which is, a topic that is timely for people my age, because it happens. To introduce our speaker today, I'm going to ask the Chief of the Bone Marrow Transplant Division, Dr. William C., to introduce Dr. Emmons.
Dr. Lederer, you will be missed here. Thank you for leading us over the last 2 years in the most difficult timing of department. Best wishes to you. Yeah. Today is my great pleasure to introduce my close and dear colleagues, Dr. Robert Emmons, to be the Grand Round speaker. As you all know, this is the third Grand Round speaking opportunity for Rob. Thank you for taking this opportunity. Dr. Emmons has been joining us since 2 years ago from Louisiana, Osler Medical Center. He has been regarded as a very accomplished bone marrow transplant physician, as well as a hematologic malignancy specialist in the field. I don't have to give too much detailed introduction because we have been introduced him multiple times in this setting. So today, I would like to welcome Dr. Emmons to give this Grand Round topic as AML 2019 updated on molecular biology and immunology. Welcome.
Good morning, everybody. I would like to say thank you to Dr. Lederer as well, and certainly for her championship of the Grand Round series. I think that will be sorely missed, and I hope we still have great attendance at these in future times. And I'd like to thank my colleague, Dr. C., and all the innovations he's brought to the institution, and just to remind everybody that we're only a few short weeks away from opening our innovative CAR-T GMP facility on campus to start that, which I will talk about with regard to acute leukemia a little later in the talk. Certainly, I have no relationship to pharmaceutical or other commercial interests, and there will be no off-label discussions with the exception of the CAR-T business that I discuss at the end, which is not yet FDA approved. So for this internal medicine audience, I just do want to remind people that the presentation of acute leukemia is subtle. There is no pathognomonic finding that one has when this presents. And as Dr. Lederer alluded to, this is really a disease of older people for the most part. And so older people that present with subtle signs, which often can be confused with many other things, can be found on CBC to have acute abnormalities, which lead down the road to the diagnosis of acute leukemia. Certainly in the fulminant form, bleeding, disseminated intravascular coagulation, obvious leukostasis, bad infections for which they're admitted often to the ICU before it's realized that they have significant numbers of blasts in their blood, are all things that can, unfortunately, be presentations, but we hope in general that these are caught earlier when people have more subtle signs. Generally, people do much better when that's the case. I will remind you, too, that there is, aside from the bone marrow and blood findings, occasionally things that present that are subtle signs as well. Certainly, splenomegaly is common. That's something that all of you should be able to appreciate, and certainly those residents who can't, please come to the clinic with us so that we can teach you about lymphadenopathy and splenomegaly. Monocytic AML can present with infiltration in the gums, a sort of unusual gum hypertrophy, which you don't see in other diseases. Central nervous system involvement is very common in ALL, but is often seen in certain forms of AML as well. And so sometimes neurologic findings can be a part of this. And occasionally there can be actually a tumor of these cells, so-called granulocytic sarcoma. That's rare in subtypes, with the exception of some subtypes of AML. The diagnosis, of course, depends on more than 20% blasts in the marrow. Less than that, we artificially call this myelodysplasia. And I'll talk about the tie-in between myelodysplasia and acute myeloid leukemia. That is the genesis of leukemia in older people for the most part, with the more intense molecular changes being seen in younger people and having better prognosis on that basis. Another thing that those will be practicing in smaller hospitals need to be able to recognize is blasts on a peripheral smear. So if you're working in an outside emergency room or you're a hospitalist admitting a sick patient and they tell you there's an abnormal CBC and the people in the lab are uncertain what's going on, you should really be able to go down to that lab and make a decision as to whether there's something that you need to call either a different center or another specialist in your hospital so that things can happen more quickly. Again, delayed diagnosis of acute leukemia is a killer, especially for older patients and especially in the setting of imminently curable leukemias like M3 or APL, as we'll discuss. It is critically important that those things are recognized as fast as possible. So you as internists who will be seeing these people many times in the front line must be able to recognize abnormal CBCs and blasts when they are present on the peripheral blood. Again, those house staff who are interested, please come to our clinic and we can teach you about how to recognize those things and take you down to the lab to take a look at enough slides for you to become familiar with this. One thing I'd like to emphasize and allude back to my previous grand rounds some months ago where I talked about the immunotherapy of cancer is that we now know a lot about the relative mutation rate of various cancers and how that ramifies for things like direct therapy with molecular blockers as well as immunotherapy. Those that are more on this side of the slide, that is diseases like melanoma and so on, have very high mutational rates. And because they have high mutational rates, they're more amenable to immunotherapy attack naturally from our own immune system and through manipulation of T cells. Those on the other side of the slide, however, have relatively lower mutation rates, although that you'll note for AML, there is a very wide dispersion in terms of the mutation rate. And remember, this is a log scale of mutations. On average, there's only about 13 mutations found in people with full-blown AML, but that varies quite widely, and certainly patients who have dysplastic syndromes in which they can have often many, many times the number of mutations that people with de novo leukemia who are younger present with very powerful molecular changes can be more amenable to certain immunotherapy approaches. In addition to natural mutation rates, I will just mention that there are certain things that increase the likelihood that somebody might have mutations that lead down the road to acute leukemia. There are certainly exposures in the community, and Kentucky is certainly a state very familiar with this, especially in the eastern part of the state. Previous chemotherapy exposure. Something that's become more apparent recently, and I'll allude to this in a couple slides near the end, is that there's many more congenital, that is, that you're born with, the genetics that can lead down the road to leukemia than we realized, say, even 5 to 7 years ago. And that's a very rich area of study right now. Certainly we knew things like Fanconi anemia and Down syndrome, but there's many other more subtle molecular findings that you can be born with that predispose you to leukemia. So we generally don't think of acute myeloid leukemia as a familial syndrome, and that's generally true. However, there are certainly family clusters of this that we're becoming more, that are being recognized more often. And certainly the more common situation is pre-acquired syndromes like myelodysplastic syndrome, myeloproliferative disorders, aplastic anemia, or paroxysmal nocturnal hemoglobinuria, which are acquired genetic syndromes that can often lead the way towards acute leukemia. I hearken back to this thing that I've mentioned in my last talk as well about how since the mid-1800s, the benzene tree of coal and natural gas has led to plastics and other innovations that have led to a wide variety of exposures that we didn't have 150 years ago to the degree that we do now. And this is a very good article that sort of reviews the very, very many chemicals that humans and other life forms are exposed to now that do, in fact, increase relative mutation rates beyond the natural mutation rates that we're all subject to and lead down the road to increased incidence of cancer, including acute leukemia. The good news, if there is any, is that despite the relative increasing incidence of acute leukemia across the board because of the aging of the population predominantly, you'll note that, if anything, the relative death rate of leukemia has been on the decline somewhat. And this is testament to the many advances that I will mention in the slides upcoming. The other thing to certainly emphasize is that acute myeloid leukemia, as opposed to acute lymphoblastic leukemia, is really predominantly a disease of elderly individuals. It is not something that you generally see in the pediatric setting, although it does happen occasionally. There's much more ALL than AML in that situation. When it does happen in younger individuals, again, it tends to be very powerful, fewer genetic abnormalities that lead down the road to the blasts, whereas if it occurs in older individuals, it is a mishmash of many different mutations that vie with one another over time. And again, just to emphasize this fact, myelodysplastic syndrome is often the leader for this in older individuals. The good news there is that the relative incidence of myelodysplasia, even across all ethnic lineages, has been decreasing somewhat since its peak incidence sort of in the early 2010s. In the state of Kentucky, we certainly see a death rate associated with acute leukemia, although I will mention that this has been improving, as I'll show in the next slide, over the last few years. The leukemia death rate is just that under ovarian for women and just under pancreas for men, but that is certainly not a rare reason for people to get into trouble. The important point about this is that these statistics have been improving, and certainly for younger individuals, we, over this period of time till the millennium, made significant strides in survival based on chemotherapeutic approaches and the advent of innovative strategies for allogeneic bone marrow transplant. But what you'll see since the turn of the millennium is that we finally started to make a difference with the larger number of older individuals, and this has accelerated quite a bit, which this slide does not show, since 2011, with many new innovative strategies approved by the FDA and many in the pipeline. And so for the lion's share of the patients with acute leukemia, we have much less toxic strategies, much more successful strategies for getting people into remission. We've also changed classification of acute leukemia from things you may have been exposed to in your medical school, like the FAB criteria, to those that emphasize molecular biology rather than morphologic changes of these cells under the microscope. And these emphasize the genetic changes that we see under the microscope that direct now our prognosis and therapeutic decisions for these patients. So here's a metaphase spread that's been cut up and pasted onto this, showing trisomy 8 and a change with a 15-17 translocation that's the hallmark of acute promyelocytic leukemia. So some changes that lead down the road to acute leukemia are major changes in genetics that can be seen on a metaphase spread. Most, however, are not, as we'll talk about. But this has led to the World Health Organization, which was updated in 2016, classification of acute leukemia. Obviously, this is a very busy slide. I do not expect you to come away and memorize this. But what I do want you to appreciate is that we have a very good prognostic understanding and now treatment decision understanding based on these classifications as to how we should treat people, how we should think about them with regard to therapies like an allogeneic bone marrow transplant, and how we should think of them in terms of aggressiveness of therapy overall. There are some that still rely on morphologic classifications. Certainly patients who have multilineage dysplasia, who may have many genetic disorders, ahead of time are classified in their own setting, previously therapy-related acute leukemias, not otherwise specified groups. And again, this germline predisposition, which has now been more readily recognized, people born with specific genetics that lead them down the road to a predisposition to acute leukemia. So let's spend a little time talking about the good stories, acute promyelocytic leukemia, core binding factor leukemia, and those that have normal cytogenetics with either NPM1 or CEBP alpha mutations. So just to remind everybody, there's something called the retinoic acid receptor, which can associate with when the 15-17 translocation happens, a partner gene, which then overexpresses this and leads down the road very powerfully to both a proliferative signal and a dedifferentiation signal that is, again, the hallmark because of a dominant negative mutation to cause these cells to change to these acute promyelocytic blasts. And there's very little else that has to happen. So very few other genetic changes have to happen for this to fully express as acute leukemia. There's a drug, all-trans retinoic acid, which binds to this receptor, downregulates the fusion protein, and vastly changes the outcome for patients with this disease. But I will emphasize again and again the speed with which patients are recognized to have the syndrome and get their first dose of all-trans-retinoic acid is the difference between life and death. This disease kills not because of the significance of the number of blasts in the blood, but because of the coagulopathy and disseminated intravascular coagulation that happens. And so the speed with which you get that reversed determines whether the patient lives or dies. These are the sort of things that you might see in the peripheral blood under the microscope if you, again, on a call for somebody who comes into the hospital with bleeding problems and a high white count. Recognize that there are occasionally hypogranular variants, so not all patients with this are going to have these dense granules in the cytoplasm, but most do, especially those that have the highest risk of DIC. The hallmark of this is the sort of CD34 and HLA-DR, which are usually present on most myeloid blasts, being missing. So that's another clue that you might be dealing with APL. And of course, there are variants beyond the 15-17 translocation that can lead you down this road, but that's the most common one. Again, to emphasize, early all-trans-retinoic acid is the key to survival in this disease. We're trying to convince our surrounding hospitals that refer our patients that the emergency rooms should in fact have this in stock because it is such a big difference between life and death for these patients. Low-risk patients, those who present with a white count under 10,000, can now be cured without doing any standard chemotherapy, only receiving all-trans-retinoic acid and arsenic trioxide, both of which were discovered by an innovative Chinese researcher many years ago now. So your cure rates are really in the 80s for this now, with months of therapy with just these two drugs, no standard chemotherapy exposure at all. High-risk patients, those with over 10,000 cells at presentation, again, have a very high risk of DIC and bleeding complications, including calamitous central nervous system and gastrointestinal bleeding. But again, if rapidly treated with these two drugs and other cytoreduction agents, idarubicin in some cases, and this drug gemtuzumab, which I will mention in the next slide, which may replace idarubicin, which can be cardiotoxic, and therefore you want to minimize exposure, can cure these high-risk patients even with bad presentations with bleeding. But again, the speed with which they get on all-trans-retinoic acid is the determiner of life and death, and it is very important for you as internists to recognize this because you're usually in the front line when this is detected. So what was old is new again, the gemtuzumab azithromycin story. So this is a drug that was developed a long time ago at this point. It's an antibody which binds to something called CD33 on the surface of these cells, and it's attached to a toxin called calicheamycin, which when taken up by the cells and released can cause DNA damage and apoptosis of the cells. However, at the time this originally came out, we were largely giving aggressive chemotherapeutic regimens to these patients, which also caused hepatotoxicity. These patients were often also going to allogeneic transplant when they were exposed to this agent, and that led to calamitous problems with very serious liver complications, including sinusoidal obstructive syndrome, or SOS, also known as veno-occlusive disease, and Pfizer voluntarily removed it from the market in 2010. However, in the modern age of therapy, where we're giving much less intensive strategies that cause much less liver toxicity, and in the case of good risk leukemia who aren't going on to allogeneic transplant, when this drug was brought back at lower doses and less aggressive therapy was applied, it turned out to be a very successful strategy to control these and was actually approved by the FDA in 2017. The other thing to point out about APL and about certain other diseases that we'll talk about is that we now have a very effective way of monitoring the course of disease through PCR of the specific genetic hallmark of the disease, so that we know with great accuracy that depending on the depth of remission, there is a certain time that you will have to relapse with this. So the goal in APL is to treat people with months of therapy to get them PCR negative, and if you've achieved that, then you have a very high likelihood of cure. But if you're left with even small amounts of remnant APL signal, you can say with great accuracy that depending on the number and the intensity of the signal that you're left with, that you will eventually relapse. So the minimal residual disease detected by molecular techniques has become incredibly important for making treatment decisions and escalating therapy in those who need it, with not just this, but other forms of acute myeloid leukemia. So 2017 was a busy year for many drugs in the heme malignancy space, but especially AML. I've mentioned the approval, or I should say re-approval to some degree, of gemtuzumab, which is, again, a very useful strategy now for good risk leukemias. We'll talk about some other good risk leukemias for which that's been applied to. There is a combination of liposomal daunorubicin and cytarabine. These are the two drugs, so-called 7 and 3, that we typically use, but in its liposomal form, it's been found to be less toxic and then more applicable to patients at higher doses, and certainly for older patients, this has made a big difference. Enasidenib, which is a blocker of something called IDH2, which we'll talk about, was approved in 2017, and midostaurin, which blocks a specific molecular hallmark called FLT3, which we'll talk about more, were all approved in 2017. So the next group to talk about are the so-called core binding factor leukemias. Core binding factor is a group of proteins that is predominantly RUNX1 or AML1 and core binding factor beta, as well as with others. There are specific mutations in which one of these goes wrong, and therefore downstream genetics don't happen. And just like in the case of APL, it sends a growth uninhibitory signal as well as a differentiation negative signal. Loss of either protein is lethal in embryogenesis, but if it's later acquired, as most acute leukemias are, it is not lethal. And again, this is not, therefore, one of the things that is a congenital related problem. So in graphic form, this is the alpha and beta core binding factor beta and AML RUNX1 parts. In the case of an 821 translocation, which you can detect via fluorescence in situ hybridization or FISH, here are the two abnormal yellow signals where there's tunneling between the red and the yellow and the two normal signals of green and red. This FISH study is showing us that this translocation happens in the cell. And when it happens, this disappears, and these, therefore, don't transcribe appropriately. It leads very powerfully down the road to acute leukemia. This can also happen with what we call inversion 16, and here's an inversion 16 situation in which you have one normal and one abnormal chromosome 16, and in these, dominant mutant, again, leads down the road to acute leukemia. Again, a very powerful single molecular abnormality that leads down the road to acute leukemia. This gives rise to what used to be called M2 leukemia in the FAB classification, and roughly 50% of these patients have so-called good risk prognosis. We'll talk about the other molecular hallmarks that tell us who is good and who is bad, actually, and can be cured with chemotherapy alone. These are what the blasts sort of look like under the microscope. Again, important for you to be able to recognize what myeloid blasts appear so you can give us or other leukemia centers a call to get these people to treatment as soon as possible, although this is not as immediately life-threatening as APL. And I just do want to emphasize again that APL is a life-threatening medical emergency, and the speed with which you get people on all-trans-retinoic acid is the difference between life and death. And you guys are going to be in the front seat many times finding those patients before they get to our center. The other one is so-called, in the old FAB classification, M4EO. That's the inversion 16 form of this core binding factor leukemia. They often have granules in the cytoplasm that look similar to APL to some degree, although the nucleus is different than that appears, and they do express CD34 and HLA-DR on their surface. It has a propensity for sarcoma presentation, and this is the classic translocation that is an inversion of chromosome 16. So what about when AML cytogenetics are normal, but you have blasts in the blood? So we've known for a long time from many now exquisitely done genetic sequencing studies that even if you have normal cytogenetics, there are many abnormalities that you can detect in leukemic cells. And this is a spread of chromosomes just to show the additions and subtractions that are found in large numbers of leukemia patients that have been studied over time. So the absence of metaphase abnormalities does not mean the absence of genetic abnormalities in acute leukemia, far from it. Because of that, there's now been a lot of sequencing studies done to sort of find which of these are driver mutations that have physiologic relevance for acute leukemia to make the difference in terms of, again, treatment and prognosis, aside from those that we see on metaphase spreads. And you can see that there are a lot of potential driver mutations for acute leukemia, but we're certainly going to talk about these most common that are noted on the one side of the slide. So here are the ones that we are going to focus on today: NPM1, CEBP alpha, and FLT3. These are important, two for good prognostic and one for negative prognostic, but even the negative prognostic one is an asterisk in terms of specific molecular blockers that are available now that change the relative prognosis of this type of leukemia. NPM1 is a ubiquitous phosphoprotein that shuttles between the nucleus and the cytoplasm. We know where the mutation occurs, and this is very useful, again, in patients who have normal cytogenetics, because if this is the only molecular hallmark that comes along for the ride with normal cytogenetics, it has a relatively good prognosis, and those patients, in many cases, can be cured in the absence of a bone marrow transplant. And specifically, if you are missing FLT3 and have NPM1, we often try to treat these people similar to the way we treat patients with core binding factor leukemias. The other thing to point out is that, like APL, NPM1 is very useful for the detection of minimal residual disease. So just like APL, where the goal is to get people molecularly negative of this, and if we achieve that, then we have with high certainty likely cured them. We want to get MRD negative for these patients with NPM1, and it is a very powerful prognostic predictor for these patients. So these are very useful for the decision of how to treat patients, and then also how to follow up patients and give prognosis in terms of what types of therapy they need. If they haven't achieved MRD negativity, these are the sort of people that need to still be referred for allogeneic transplant, though that's a rarer subgroup these days. CBP alpha is a little bit different in that for it to have prognostic relevance, both copies need to be mutated, not just one copy of the gene. That's different than NPM1, in which only one copy is important for the prognostic change. This is also something that can be used for a follow-up of patients with minimal residual disease, but is not quite as powerful a tool as NPM1, because you can sometimes be fooled with small amounts of this and still have relatively good prognosis. FLT3 is the bad kid compared to those others. It is a very common mutation found in 30 to 35% of AML patients in adults. And most of these abnormalities are related to internal repeats that constitutively activate the kinase. And some of them are related to abnormalities that occur in the inner loop, which also affects kinase activity, but not as powerfully as these internal tandem duplications. The size of the FLT3 clone within any particular patient, that is the number of cells affected and the number of these, does have some relevance with regard to the aggressiveness of the disease. So overexpression and overamplification of FLT3, it has relative amounts. It's not just an all or nothing phenomena. And this has sometimes prognostic relevance in addition to the simple presence of it, like NPM1 and CBP alpha. So in this way, we've been able to pull out in normal cytogenetic patients those that have relatively better and relatively worse prognoses. So as opposed to 10 years ago, we now have a better crystal ball about normal cytogenetic patients with these three molecular hallmarks. And again, this is relevant for making decisions like who goes on to get allogeneic transplant and who doesn't need to get that. So these patients usually can be successfully put into remission with standard so-called 7-in-3 therapy. Once in remission, 3 rounds of higher dose Ara-C can often cure these patients, that is, who are FLT3 negative with core binding factor NPM1 CBP alpha. And the place of this recently resurrected gemtuzumab azigamycin is being tested here to replace standard chemotherapy, so that just like APL, many of these patients may never need to see standard chemotherapy to be cured of their disease. And again, that's the innovation that you'll see me come back to again and again. The bad old days, so 15 to 20 years ago, everybody got high-dose chemotherapy with high relevance for long-term toxicities to the heart and other organ systems. These days, we're replacing those with many other innovative strategies that avoid standard chemotherapy, and especially for older patients, can lead to cures without the attendant morbidity and mortality of aggressive chemotherapy in consideration of allogeneic transplant. So what about the bad stories? We'll get to the ugly stories as well. FLT3 relapsed good risk patients and those who have IDH1 and 2, which we'll talk about. First thing to point out is that we've learned about some strategies that allow us to make better prognostic decisions with regard to core binding factor patients, because we know within that population there are additional genetics that define whether we're going to cure them with simple therapies like just standard chemotherapy or not. Most notably, there's a gene called KIT, when mutated and found in core binding factor leukemias, leads to the inability to cure patients up front. So if we find a core binding factor leukemia that also has a KIT mutation, we know that those patients, by and large, need to be referred on to allogeneic transplant. So At the University of Louisville, we constantly meet to have discussions about what innovative strategies and which of these testing things we need to consider. And this is a very important consideration because these are not cheap tests. This is very expensive medicine. And there are centers around the country that do greater or lesser numbers of these tests. In fact, there are places that do shotguns of huge arrays of tests, which are very, very expensive. To do innovative, cost-effective medicine, it's very important to keep your hand on the pulse of exactly which of these strategies make a difference prognostically for patients and really drive decisions in the clinic. And so we have a very select strategy for making decisions about how to treat patients, which we review about every 6 months to make decisions about what other things we need to add to that list. There's been 3 that we are considering adding this year that I'll talk about later in the discussion. So what about these patients? FLT3 expressing patients are often more difficult to get into remission because of the very powerful kinase force that FLT3 causes on the division of blasts. But as I mentioned, in 2017, midostaurin was approved, which is added after the 7 and 3 at day 8, which has a much improved remission rate. This doesn't mean that we can cure patients with chemotherapy alone, but what it does mean is that the lion's share of these FLT3 patients who often present with blasts in the hundreds of thousands when they come on, because again, this is a very powerful growth-inducing agent, are much more successfully put into remission and therefore become candidates to get an allo transplant. Because if you can't get somebody into remission, then you can't transplant them. If patients have relapse disease, good or otherwise, we often test for this thing called IDH2, for which there is, as I mentioned, an approved specific molecular blocker, anacetinib, that was approved in 2017. And if a sibling donor is available, we tend to try to get these patients directly to allo. If no sibling donor, we still consider matched unrelated donor haplocord transplant techniques. And again, the relative risk of these is different, and the relative prognostic difference is different depending on how well they're able to get into remission. Just a brief mention about IDH1 and IDH2. These were unanticipated additions to our leukemic armamentarium. It turns out that methylase activity in DNA, which regulates the on and offboarding of ribosomes and the opening and closing of DNA circuits, is critically dependent on some of these metabolic pathways that affect the alpha-ketoglutarate dependent reactions that help to increase histone methylation, DNA methylation, and impair cell differentiation. Therefore, patients with mutations in these, again, metabolic pathways that lead down the road to the production of these very important metabolic hallmarks that allow this to happen make a big difference with regard to methylation pathways and differentiation of myeloid and other cells. So the specific molecular ability to block these mutated proteins has made a big difference with regard to patients who have these mutations in their leukemia. So at the time of relapse of good or other risk patients, we're testing for IDH2 as well as FLT3 and potentially adding FLT3 blockers or IDH2 blockers along with reinduction therapy and decisions for transplant. So this has given rise to, this was in the ASH Educational Guideline, for example, last year, about how to think about patients who can undergo standard induction therapy across the board. There are patients with good risk disease in which gemtuzumab as well as standard induction needs to be considered. There are patients with FLT3 inhibitors, and 30 to 35% of these patients who need to be thought of for specific FLT3 blockers as well as altered doses of standard chemotherapy. There are older patients for whom standard therapy is more risky for cardiotoxicity, and therefore liposomal forms of these therapies have had better success with regard to getting people in remission without causing major toxicity to them. And there are patients under 60 who have major karyotypic abnormalities in which we're altering dose to make a difference of getting them into remission, or who need more innovative strategies to get them into remission, either because they're relapsed or because they have an insufficient response to initial therapy. So what about the ugly stories, the other ones, where we try to get them into remission and transplant if possible? We know the other stories require allogeneic transplant. The difficulty is getting people into remission well enough to get them to allogeneic transplant. Again, the hallmark of this for older individuals is that most people who get to acute leukemia who are older get there via many molecular abnormalities that accumulate often first in myelodysplasia before taking them down the road to acute myeloid leukemia. There are very ugly-looking dysplastic blasts that make it difficult for pathologists to even count the number of blasts in the bone marrow. They rely many times on immunocytochemistry, things like CD34 staining on the surface to be able to count the blasts because they are so dysplastic in the marrow oftentimes. And there are many, many genetic findings in these patients. Again, the incidence of myelodysplasia, not surprisingly, is typically higher in older individuals, which is why this kind of dysplastic leukemia is much more common in older individuals, and as I mentioned at the earlier slide, causes many more mutations in the older individuals than the younger individuals, and therefore more difficult to treat with standard therapies that are quite successful at eliminating blasts who have fewer number of molecular abnormalities but are often challenged with these very dysplastic clones. The other thing to point out is that as you develop myelodysplasia and acute leukemia, it's not true that every cell is the same, that in fact there is an evolution of clones that exists over time that have different abnormalities, genetic abnormalities that are taken on. And therefore, just like in the setting of antibiotics, in which you develop antibiotic resistance to clones of bacteria, which have innovative strategies for avoiding antibiotics, you often have the development of clones of acute leukemia that become resistant to chemotherapy in a like fashion, and eventually become very resistant clones over time, depending on the type of therapy they're exposed to. Something else that we've now determined because of the sequencing studies is the tie-in between these driver mutations and how commonly they occur amongst one another. And this sort of wheel of association has been very useful for figuring out exactly those associations that are relevant with regard to treatment and prognostic decisions. Another thing it's led to is the recognition that there are many forms of dysplasia other than full-blown myelodysplasia. And in fact, there is something called CHIP, clonal hematopoiesis of indeterminate potential, in which patients may not have any blood cell abnormalities per se. In other words, they don't have anemia or platelet or white blood cell count abnormalities, but are found to have clonal hematopoietic changes nonetheless. And then various degrees between full-blown myelodysplasia with uni or multi-lineage abnormalities with lesser genetic changes. The reason I bring this up is because of the recognition, first of all, that CHIP, that is clonal hematopoiesis of indeterminate potential, in which people don't have any blood count abnormalities but have clonal hematopoietic disorders, has been found to lead to some other interesting things from an internal medicine standpoint. One of these things is that though many of them can go on to develop hematopoietic abnormalities and even go down the road to acute leukemia, there's also a recognition, this came from mouse studies but has been validated in humans as well now, that if you have, for example, a TET2 mutation, and again have CHIP, you don't have any blood count abnormalities, but if you have this TET2 abnormality, it leads to abnormalities within monocyte macrophage lineages that alter their ability to handle cholesterol and contribute to the deposition of cholesterol in the wall of blood vessels. This is the aorta from these mice that have TET2 abnormalities with accelerated atherosclerosis. So the accelerated atherosclerosis that we see in older individuals, where we often think about this being associated with lipid disorders, diabetes, hypertension, family history, and so on, may also be related to these specific molecular abnormalities within hematopoietic cells that are clonal and cause specific abnormalities within monocyte macrophage lineages. This has again been validated in humans for heart disease and predisposition to myocardial infarction, so that we know that there is a reality that people can have clonal hematopoietic defects that don't lead to leukemia or myelodysplasia, but may lead to some predisposition to the biggest killers in our society, heart attacks and strokes. This has given rise to a paradigm where patients with lesser hematopoietic clonal abnormalities may be predisposed to things like pulmonary emboli, ischemic disease, myocardial infarction, and with additional abnormalities over time can lead to clonal disease that goes down the road to acute leukemia. But long before acute leukemia, there may be significant morbidity and mortality that we need to recognize and potentially screen for going forward, aside from the things that we do with hypertension, cholesterol, and diabetes. We also know from these genetic studies that there is a hierarchy of risk with these different genetic abnormalities that can be seen on metaphase spreads in cytogenetics and in molecular genetic sequencing studies. And some of these that are at high relevance for what we see in adults are things that we are screening for these days. The other thing to point out is that AML, again, is predominantly disease of the elderly, and there are a large number and increasing cases, especially in patients over 60, which will increase in the near term because of the aging of the population. And there are few trials, unfortunately, in the elderly that direct therapy, but this is certainly rapidly changing, as we'll discuss. There are also, as I mentioned, from that tree of molecular abnormalities, increasing relevance of certain abnormalities that we have decided should be part of the armamentarium for screening because they make a big difference in older individuals, such as the recognition of RUNX1 abnormalities. Remember, that's part of the core binding factor domain, but when it's seen as a single abnormality with mutation, has a big relevance for prognosis, as well as AXL1, which is a gene transcription regulator and is seen in 16% of patients over 60, and something called TP53. P53 should be familiar to everybody in this audience. It has relevance to virtually every human cancer. I will mention in passing that one of the reasons that elephants, who have many more cells than we do than humans, despite the fact that they have less relative cancer, have 17 copies of P53, whereas humans and primates only have one on each of their chromosomes, which is one of the things that saves them from this problem of missing TP53 and leading down the road to many genetic abnormalities that lead down the road to aggressive forms of leukemia. In 2018, the FDA was again quite busy with regard to many innovative strategies in hematology and heme malignancies, but I want to focus on some that have relevance to our older patients, and that is venetoclax, a BCL2 blocker, and glastigib and gilteritinib, a more powerful FLT3 blocker, as well as an IDH1 blocker, inacitinib. This is my chance to mention that although the genetics of leukemia in older individuals is very complicated, it turns out that if one is able to manipulate the on and off loading of genes from ribosomes, you can have great relevance with regard to controlling these many abnormal gene circuits. And so there are certainly genetic things like these two, TET2, and other methylase-related genes that by themselves can cause problems and turn these things on. I've mentioned the metabolic pathways, IDH1 and IDH2, that influence this as well, and drugs that specifically can have effects on methylation of DNA. In fact, it's not just methylation, but acetylation that's important in how we turn on and off gene circuits within human and primate cells. And there are many drugs that have been approved and are in development that have relevance for this strategy of turning on and off these genes. And so in patients who have 15 or 20 things wrong in gene circuits that are on abnormally and lead to dedifferentiation and high replication of these cells, interfering with these pathways has been tremendously useful for being able to downregulate these rapidly growing blasts. In addition to that, and I realize this is a busy slide, we've talked about a couple of these things like the inotuzumab azigomycin, the gemtuzumab. We've talked about FLT3 inhibitors. We didn't talk about BCL2 inhibitors, and this was, again, a surprise. These BCL2 inhibitors, as the name implies, B-cell lymphoma 2, were discovered in B-cell lymphomas and have great relevance for things like follicular lymphoma and CLL. It was unanticipated that this apoptotic pathway would have relevance in acute myeloid leukemia, but it turns out if you block this BCL2 pathway in patients with very dysplastic acute leukemia, you can actually have great relevance in addition to the blocking of either acetylase and methylase pathways. Hence, in older individuals who cannot withstand aggressive chemotherapy, most can withstand a methylase inhibitor called azacitidine, and most can withstand a BCL2 blocker like venetoclax. And this combination of azacitidine and venetoclax has a very high rate of control of disease in older individuals. It does not cure people, but it often controls disease for months to even years. And for those that can, sets the stage for us to be able to get them to transplant, even if we can't use aggressive therapies because they have pre-existing cardiac or other limitations that don't enable us to give them aggressive chemotherapy. Last thing to mention is the inherited germline abnormalities that lead to acute leukemia. Some of these present without pre-existing disorders or organ dysfunction. Some of them have pre-existing platelet disorders that people have had since their youth, or pre-existing organ dysfunction. These are increasingly recognized, and they can be recognized therefore early and oftentimes intervened earlier. And it's given rise to long lists of things like this that you find in publications now, in which you can screen for these things in people with these abnormalities and determine ahead of their transformation to acute leukemia who is at risk for this. So, why do patients who are in complete remission still relapse their acute leukemia? So, as I mentioned before, leukemia, that when it becomes leukemia, is not a single cell, but a bunch of different cells with different clonal realities in terms of the type of mutations within them. And sometimes, even when you're successful at getting people into a minimal residual disease state, you still have a residual clone that can then expand and come back with different genetic mutations and predispose people to a relapse of a different kind of acute leukemia. And so again, our molecular techniques to determine minimal residual disease are very important for establishing cure in acute leukemia and being able to detect cells down to 1 in 1 million cells. I've mentioned many of the things that are on this slide. I just want to point out that there are many avenues of discovery, certainly allogeneic transplant that we'll discuss a little bit more, monoclonal antibodies, chimeric antigen receptor, CAR T cells that I'll talk about a little bit, CD33 directed cells such that you direct T cells into direct attack of AML without changing the T cell genetically, but by reorienting it, and things that we won't talk about today, cytokine strategies and vaccine strategies. Let's talk briefly about stem cell transplant, because since the mid-70s, we've been doing allogeneic transplant. As I mentioned, we used to do allogeneic transplant only with very aggressive chemotherapeutic regimens, and we had varying degrees of success for good, intermediate, poor, and unknown prognostic types of acute leukemia. These things have changed quite a bit over the last 10 to 15 years with innovative strategies to get people into deeper remission prior to transplant, some of which I have discussed today and some of which I have not. It's also important to point out that whereas we used to use exclusively very aggressive chemotherapeutic regimens to get people to transplant, we now take people down to very low levels of TBI of only 200 centigrays, for example, and fludarabine, very, very low level, which can be tolerated by virtually everybody, even older individuals. And these strategies still allow an allo transplant to take place, but very, very much decrease the relative morbidity and mortality of the whole endeavor. We've also been able to do comparisons of the relative ability of these regimens to get people into remission and keep them in remission for the 6 to 8 weeks necessary for the allo effect to take place. And so there are publications that are done to compare the relative likelihood of this that we look at with different subtypes of leukemia to make decisions about what type of therapy and what degree of risk we should expose to somebody to with their allogeneic transplant. However, there are still patients who relapse after their either sibling or unrelated donor transplant, and there's incidence of graft versus host disease that can determine problems. And so we're still working on strategies to make this successful for everybody. However, it is important to point out that over the decades, we have made a difference with regard to morbidity and mortality through better supportive care and better HLA matching, as well as better strategies and prognostic decisions to give people the right type of transplant that is justify the risk for their particular disease. I will mention, which I certainly talked about more in my last talk, about CAR T therapy. This is very exciting therapy that will be launched here within just a few weeks as our GMP center comes online. This is the idea of taking the patient's own T cells and introducing a new gene that targets these T cells from the individual directly towards their cancer. There are certainly problems with CAR T therapy. It isn't perfect. There is T cell specific abnormalities, antigen escape from the surface of the cells, persistence of the cells that lead to problems after the therapy. But for patients who can't get to allotransplant for one reason or another, CAR T therapy has become a very important additional strategy to try to get more cures. We will be starting with a CAR T vector specific against CD4, mostly lymphoid malignancies, leukemias and lymphomas. We will have one that's against 2 targets in multiple myeloma and other plasma cell disorders, and one against acute myeloid leukemia that will be headed by Dr. Hijazi in our group. It's important to point out, too, that we're getting a lot smarter about the design of these CAR T cells. We will be, by and large, in our program, looking at 2-signal CAR T strategies, but there are many innovative strategies for targeting these diseases and modifying how they work. And in fact, you can even have a CAR T cell that has an on signal and an off signal, such that you have a tumor cell that doesn't have the off signal and has an attack, and a normal cell that has an off signal that prevents it from being attacked. So many, many innovative ways that we're using not just T, but natural killer cells and other forms of the immune system with genetic manipulation to target and address cancer. So, acute myeloid leukemia is related to clonal evolution, and our understanding of that clonal evolution has advanced significantly over the last 10 years. It is predominantly a disease of the elderly. Remember the benzene tree that we're all unfortunately exposed to, and we need to remember that in terms of our governmental strategies for limiting this exposure. And survival is improving with less toxicity over time, especially for older individuals, especially since 2010. Modern clonal understanding has included our understanding of this thing called clonal hematopoiesis of indeterminate potential, or CHIP. Remember that as a contributor to the biggest killer in our society, atherosclerotic disease. This is a big surprise and something that we will see more of in the literature, I'm sure, to come. Stronger, lesser molecular changes for younger individuals, such as core binding factor leukemias, acute promyelocytic leukemia. Please, please remember, early all-trans retinoic acid for patients diagnosed with APL is critical for survival. So when you see these patients, please, please, please get them to a leukemic center as fast as you can, or try to get ATRA into their system. Molecular prognostication in myelodysplasia and AML, including signal and clonal prediction, has helped certainly in core binding factor leukemias to determine who can be cured with chemotherapy alone and who needs other strategies. FLT3 is very common in AML and has a specific inhibitor now. It's made a big difference with regard to getting these people into remission. NPM1 is common and useful for minimal residual disease detection. Interestingly, FLT3 is not. That's not a thing that you can use to make decisions about minimal residual disease after treatment. CEBP alpha is another, like NPM1, good hallmark, but it's only when it's biallelic that it makes the difference. AML in the elderly, developed typically from myelodysplasia and other genetic abnormalities, and the importance of screening for things like RUNX1, AXL1, and TP53 to understand the degree of risk for patients. Global inhibition of DNA kinetics through methylase and acetylase inhibitors with manipulation of other cellular dynamics like BCL2 inhibitors has made a huge difference in our ability to get older patients who can't tolerate aggressive therapy into remission. Considerations for therapy, including transplant, depend now on molecular prognostication amongst the various clones that people present with over time. Modern therapy is changing the landscape for treatment in place of transplant and emphasizing less intense therapy when appropriate for patients according to genetic stratification. Minimal residual disease predictions for early intervention before and after allotransplant are critically important, as we know that even after allotransplant, we often use minimal residual disease to determine whether the allo effect has taken hold and is enough to keep people in remission, or we need to add additional medicines to keep people in remission long enough for the allo effect to take hold. And our evolution of immunologic understanding has given rise to new innovative strategies such as CAR T therapy, CAR NK therapy, and this will expand in the near future. I will mention in passing as well that everybody is probably aware, a couple of weeks ago, the new version of CRISPR was announced that does a much better job at being specifically able to cleave out and change genetics. And so the future for things like CAR T strategy is to develop T cells that have stripped out their T cell receptor and their MHC genes, such as their agnostic T cells, and could become off-the-shelf drugs with additional genetics to target cancer. So whereas CAR T and CAR NK therapy are currently quite expensive because they have to be personalized to the individual, the future is to develop those type of T cells that can be given agnostically to individuals to specifically target things like chemotherapy was in days of yore. So this is a very interesting area, very expensive area, but that price should drop significantly as those new strategies come online, which have been enabled by, again, the rapid understanding of things like CRISPR and its cousins that have now been able to manipulate not just things within the things we're talking about today, but many other things, including the very controversial area of changing the human genome and what is to come with that, which we all need to keep track of. And so with that, I will pause and ask for questions, and thank you for your attention this morning. Yeah, so you make a good point. So right now, there is discussion of telemedicine for benign hematology issues because benign hematologists are a vanishing breed across hospitals. A lot of, heme malignancy patients like Dr. C and myself. And there's enough of us so that telemedicine hasn't, at least currently, been thought to be as important for heme malignancies. But interestingly, for benign hematology, it's very rare to find board-certified benign hematologists. And so at ASH this year, in fact, there's a big discussion about telemedicine and bigger centers in the country that will have outreach to other centers to do diagnosis of hemoglobin abnormalities, clotting abnormalities, a variety of things that people don't have, even in academic centers oftentimes, enough expertise to really do well. Now, the recognition of blasts has not yet been found to be that important. And with regard to your first point, most labs, if there are abnormalities, will automatically reflex to do a differential these days. Now, there may be smaller hospitals where that isn't the case. You need to be aware of what your hospital does, but certainly this hospital automatically reflects to do that if there are abnormalities on the CBC, which also should automatically reflex for at least a pathologist to take a look at those cells under the microscope, if not a hematologist if available on staff. Yeah, the only issue with that is it's a very expensive form of vitamin A. And that for that reason, unfortunately, there are many hospitals that don't stock it. And unfortunately, if you don't stock a drug like Atra, it often takes days, not hours, to get it. That's bad news. Its shelf life isn't so bad, though, so that hospitals really should be keeping it in stock. So we fight a battle here in this state and other states about, whether or not that's something that people shouldn't or shouldn't have on formulary. But I completely agree with you myself. You only want to have one of these mortalities happen to realize how terrible this can be, and especially given how curable that disease is if you're able to intervene on time. Thank you for that comment. Thank you, everybody. Indeed. Thank you. Well, I enjoyed it too. That's right. Well, right. I mean, just to be able to recognize as well. I mean, these are things that often will come to a hospitalist's attention. Right. At night, the older person who comes in, and all of a sudden there's an abnormal CBC, and oh my goodness, what's going on with this? If you don't recognize it till the following, this is the stuff that we would really like.
Yeah.
Yes, of course.
it actually flashes twice.
Yeah.
I just pointed that out to you.
A little confusing, yes. Thank you for your help, as always. Yes, sorry. A lot to cover. Yes. Yeah, very interesting. Yeah, it's very interesting what you're telling me because, of course, wrestle with graft versus host disease, right, which is a valve disease-like disorder. So if you find, advantage with this, we would love to know about that because that's something that we would like to use.
I've actually done some work with a micro